And welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
Our guest today is Dr. Jane Valentine, talking to us about her recently published article, Botulinum Toxin and Surgical Intervention in Children and Adolescents with Cerebral Palsy. Who, when, and why do we treat? Welcome, Jane. We're really excited to have you here with us today.
Thanks, Ash. Great to be here.
And hi, Dana. How are you?
Hello, I'm very well, thank you. It's great to be back.
So, Jane, we normally start this podcast with a little bit of an icebreaker to help everyone get to know us a little bit better. And the question we thought we'd ask today is, what is your ideal holiday destination?
Okay, well, I'm thinking destination in COVID times, and anyway, I think WA is pretty specky, so I like isolation and basically either right up north or right down south. So recently been to Bremer Bay with my kids and grandkids, and it's spectacular. So I'd love to go back.
Mm-hmm.
Yeah,
that's beautiful. Very nice. That sounds like a nice holiday.
Absolutely. I think I agree with you. This period of COVID has meant that we've had to explore our own backyard a little bit more. Not that I've been able to do that all that much, but if I could, I'd really love to go up north and visit Carragini and take in all the spectacular surrounds of WA.
We're really lucky, in WA. It's pretty cool. Now, you guys have all described nice holiday destinations with beaches, and they sound really, really good. But what I love, and I'm hoping everyone's gathered this already, is I really do love and enjoy eating in nice places. So I like restaurants. I want a big city where I can go and visit restaurants with like lots of Michelin stars and just explore new things in that area. But, that's a consistent message from me, I think.
Yeah, I think so. Where does have the most Michelin star restaurants?
France, certainly.
Surprise.
Hence the number of visits to France.
Well, we cannot wait to get stuck into this paper today. As we said, our guest is clinical professor Dr. Jane Valentine, who is a paediatric rehabilitation physician and head of research for the Kids Rehab Department at Perth Children's Hospital in Western Australia. Dr. Valentine's published over 50 papers and has had a really large part to play in establishing Kids Rehab WA as a statewide integrated tertiary clinical research, education and training unit with an established consumer reference group. Jane's work that we'll be discussing today is truly groundbreaking because the majority of evidence for interventions in children and adolescents with cerebral palsy is often limited to the short term, and her papers offer excellent insight into the longer term outcomes for these populations. So Dana, let's get into the background.
Yes, let's definitely get into it. Before we get into all the details, let's just acknowledge the entire authorship group. So Jane is the lead author, and as amongst the other authors, we have Sue Ann Davidson, Natasha Baer, Eve Blair, Rosalind Ward, Ashley Thornton, Kate Stanage, Linda Watson, David Forbes and Catherine Elliott. And I do love that there's an entire team that's associated with this. These represent big teams within our hospital that we're really proud of. And do you notice I said your name in there, Ash, as well? Part of the group. Love it. Okay, let's go into the PICO format. So the participants that were involved in this were children and adolescents with cerebral palsy born between 2000 and 2009, attending a tertiary service in Western Australia. And the intervention is those who had undergone medical and surgical interventions that aimed to improve gross motor function. This was a retrospective audit that was designed to understand the long-term outcomes with regards to gross motor function. Now, the outcome of this is really, really interesting. This audit confirms that there is stability in the GMFCS level in the majority of children. In fact, long-term use of botulinum toxin within an integrated, evidence-based clinical program is not associated with loss of gross motor function. Now, here are some interesting stats that I really love to see. They're really important for us when we're talking about the number of treatments children received. Of the cohort, 53% of children received 4 or less botulinum toxin treatments, and 3.7% of children received more than 20 treatments. Children within GMFCS levels 4 and 5 had 5 times the odds of surgery compared to children within GMFCS levels 1 to 3. So this work and some of these stats are really useful for us because it provides important information that can be used in discussions with families with regards to the timing and the use of botulinum toxin and surgical intervention for motor function in children and adolescents with cerebral palsy.
Such a huge body of work, Jane. And I was hoping that to start with, we could maybe travel back in time a little bit and you could explain to us about the development of the database that complements the Cerebral Palsy Mobility Service at Perth Children's Hospital, and how it was developed and how it facilitates research.
Yeah, sure. Thanks, Ash. Thanks for that lovely introduction, Dana. Basically, we started using botulinum toxin in children in 1995, and we were fortunate that we basically, late at night, drew a piece of paper with boxes on it, trying to write down the information that we thought we should record. And initially, it was very much paper-based, but we, with great expertise from Sue-Ann Davidson and our team, built it into a clinical database. And so we've been able to record every dose of botulinum toxin or surgical intervention that's been provided to our children since 1995. And the strength of that, I think, is most importantly for the patient. It's like a default electronic medical record. We don't have that. We're not going to get that for some time. So as parents will know, when they come to clinic, volumes are lost. We can immediately find exactly our history of intervention. We can track the stability of their assessments that we've done. So it's very helpful. But in particular, it offers us also a really important way to track things over the long term for large population.
Yes.
I think the other really important thing that we've been able to do with this data is show that not only, I think, contributed largely by isolation and an amazing fact that the majority of our population and our team don't largely move out of WA for a long period of time. So we can record everything that we've done for that length, and it represents really a population data, complete population data for a long period of time.
We've spoken a lot with previous people who've been on this podcast about the strength of population-based data and the wealth of information that you can get from that. And what I'm really interested about this amazing set of data is what you've reported here with regards to GMFCS stability in this cohort. You report that 75% remain quite stable in their GMFCS levels. Now, I think it's worth talking about why this is important and why was this one of the things that we looked at.
Well, I think the GMFCS curves have been really critical in our understanding, parents' understanding of motor development for children with cerebral palsy. The original curves that were done with Peter Rosenbaum and his group were children who'd had botulinum toxin were excluded. So this became a population that we can now look at who are treated, and we can see that their stability over time. There's been very clear recall, both by ourselves as clinicians, researchers, and particularly parents around the world, for understanding long-term outcome of intervention. So we've really felt the need for that. So we've been recording children's GMFCS levels each time they come to clinic, and it goes into our database so we can track stability. And for many patients, we have more than 15 entries of GMFCS level over time. So whilst the GMFCS is very clearly not an outcome measure,
that's right. Yep.
I think it's important to acknowledge that it achieving the first step to say that we understand how much we treated this population and that we can show that they stayed stable is, I think, a really important, reassuring fact. I think there's a lot of concern, in many cases misinformation about how botulinum toxin is used, and certainly concerns, and we can talk about more of that. But overall, it has very good safe evidence and very good functional outcome.
Yes.
And so this was a way to look at its use over time, and I think it'd be really clear we would have picked up a substantial change if there'd been that. So this is one of many things, ways to look at the use of botulinum toxin in a population.
Mm-hmm. Yeah, there's so much great strength to that in terms of what we can say when we're talking to families about planning and the role of it. So let's go into that in a bit more detail in terms of the role of botulinum toxin within this population and what we're expecting to see as a result.
Well, I think, as everyone knows, the population is very diverse, and the use of botulinum toxin is never on its own. It's always very much in a team-based decision, both with the parents, the child, the goal-based decisions, but with the community team as well as our hospital team. But I think if you look at the children across the different GMFCS levels, say if we start with children GMFCS level 1, we're really clear that we're not treating, the majority of those children we do not treat.
Yeah.
And those that we do treat, we don't treat very often.
Yeah.
And we're treating them, their peak age is around 6, and they're not having that many doses. So it's during a period of rapid growth. It's always combined with strength training and goal-based outcomes in conjunction with all of their other therapy needs. So I think if we understand it's where it sits in that paradigm, in the example that I just gave you, and we're not, but I think we have to be able to argue that. We have to show that's what we're doing. So the strength of this data is this is what we're doing. We also audited this database. It's over 90% accurate. We know we've done a lot of work to say that the data is actually accurate, and that really, if you choose to use it, it's in a sub-cohort for a short period of time with monitoring. And I think they're really the important way to understand it.
Okay, Jane, so what I really liked in the data that you presented was the individual GMFCS levels and the incidences or the number of times they had botulinum toxin. And what really stood out to me was for the levels 4 and 5, and the reasons why they had botulinum toxin was for care and comfort kind of reasons. Can we talk a little bit more about that and what that might mean?
Yeah, I think that's really important. I think really a lot of those goals are about that the child themselves. Care and comfort can include management and pain as well. So I think they're often obviously come together because of the need for extra care. So I think within that, I think it's probably important to mention that it's not the sole use to manage care and comfort. These children, you really need all the other background issues of support for equipment and a lot of the other interventions provided by therapy. But it can have a very targeted role, and if you understand what the goals are and if it increases the ease of everyday care that has to be done many times a day, then I think you have a substantially positive impact on that. And if you can avoid the use of centrally acting drugs, now often they need to be combined, and that's a very good outcome for many children. But at the same time, remembering that botulinum toxin works focally and works on the muscle that you put it in. So if you can avoid the central effects of centrally sedating medication, I think that's a really good balance as well.
Yeah, yeah.
So, Jane, the other thing that I was interested in is movement between those GMFCS ratings. And in the paper, you talked about improved function for around 26% of the GMFCS level 2s, around 27% of GMFCS level 3s, and 22% of GMFCS level 5s. Could you talk to us about kind of why that might be and what that means, I suppose, clinically for these children?
Well, I think the GMFCS curves are curves of motor function. So if you improve your motor function to go down a level, so to speak, then by definition you have more motor function. And that invariably can offer you more independence and more opportunities. Not always, but often. So that is implying, certainly, we do know that adolescents, as they grow, certainly do have in the GMFCS levels 3, 4, and 5, there is deterioration with adolescence and growth. So we didn't see that, which I think is really reassuring in itself. So I think we have to be clear. We don't, whether it was exactly just the botulinum toxin or the surgery. We've done a separate paper looking at a smaller sub-cohort to do that. I think the issue, and there's been some other big population studies on these curves come from Sweden in particular, and they've shown the same stability. But we're trying to say, well, actually, you have to say what interventions you did to maintain the stability. And that's really what we've tried to say, is we need to look at this in more detail, and we have to look at subpopulations further to really to say, well, that group that improved, how did we do that? Was it that they were more compliant, they had better therapy, they had a mixture of more botulinum toxin, less botulinum toxin? But our take is that actually we would expect, if we come in at the right point and we have comprehensive therapy, we have comprehensive exposure to really good state-of-the-art medicine,
yes,
and we can put in after our intervention, which in WA we have the capacity to do, all that's required to maximise our interventions, we would hope to actually create that level of improvement. And I don't think we should underestimate that. I think we have to look at it in more detail. But I think it's really reassuring. And in fact, we had, therefore, rates of significant improvement, rates of stability, and smaller rates of deterioration than the other populations.
Yeah, so I think that really addresses something that you often hear anecdotally, just through the grapevine about, and I think it's misinformation a lot of the time about the use of botulinum toxin causes deterioration, you shouldn't have it too often. And a lot of those times you hear that and it gets perpetuated. And let's talk to that a little bit, because I think that's something that we hear a lot. What would you say to that when you hear someone talking about it in that way?
Sure. Well, I mean, I think it's any medication that you use in a child, and particularly a growing muscle, we really have to look at. And we've been part of the driving international team to look at muscle in children who've had botulinum toxin, because I think there is concern in the animal literature that there has been changes in muscle bulk, substantial muscle bulk changes in the animals. And so we were very fortunate through Sian Williams' PhD and Caroline Alexander's PhD to look at how muscle volume has changed post-botulinum toxin. And really what we saw was much smaller, very smaller reduction in the muscle size that following botulinum toxin in the first month or so, and that corrected over time. But more importantly, that we saw increase in the muscles that weren't injected. And most importantly, remember, we documented that the children did well. So I think we know that we need to keep our eyes on this. We know we need to do really strength training, and we know we need to do the least dose as least often as we can. But if we do nothing, we know that the children will run into more problems with avoidable complications. So it's a line of experience. It's a line of people putting all this data together to say, well, in fact, we're not over-treating. We're treating, 40% of the children who are mild get no treatment at all. And those that do get treated, the majority are not getting very many doses. They're getting under 4. The children who are getting this, there was about 4% or 3.5% of children who got more than 20 doses. Now, they are children with really significant dystonia, and that's a very different subcohort of patient that you are treating with significant pain and impaired function. So that can be a child with hemidystonia or more sort of forelimb involvement. So I think we really have to understand and acknowledge the concerns, and what's driven so much of our research is that we have a duty of care to actually investigate this. We have a population, we have an amazing group of kids who are very agreeable to coming in and having MRIs, who come and do studies, really engage parents, and I think we have to keep looking at this. I think we really have a duty of care to do that.
And Jane, you touched on some of the work that Sian and Caroline have done previously, but could you expand a little bit more on why it's so important that we ensure muscle strength is maximised post-Botox?
Well, I think we know that if you strengthen, it does directly correlate with the increase in muscle size. So that in itself is from the MRI imaging and reassurance of if botulinum toxin induces some loss of muscle, there is a way to increase it, as well as already the fact that the other muscles which can now work better are increasing in their volume independently. So I think that's really important. I think the other thing to acknowledge is that, children need to be active, and the evidence from how many steps we should all be doing each day, how many steps children should be doing every day, let alone intensive steps, and how much the Australian population does be they have cerebral palsy or not, does less than they should is very clear. So if by using some botulinum toxin you create more function, you do more steps, you participate more, basically you have the benefits of participation, but you're also driving improved cardiovascular health, you're improving BMI. I mean, these are the long-term high-risk outcomes for these children, and we can all measure R1 and R2, but really we're really about driving long-term outcome of function and participation.
Absolutely.
And I think that's the part that's really unique that I really want to start exploring from here. We've spoken in brief a little bit about, integrating it with therapies. We're never looking at botulinum toxin on its own. And I think sometimes when we're comparing and looking at data, it's really worthwhile looking at what happens after. And Jane, you've been instrumental in setting up a program here in WA where after you have botulinum toxin, you then also have what you call post-intervention therapy services where they are followed up with therapy within that window. Can you talk a bit about that? Because I think that's really significant that needs to be highlighted.
I think we were really fortunate at the time of our significant increase in funding around 2005, and we actually based the model of PITS, post-intervention therapy service, on what was being offered through Melbourne. And it makes sense, doesn't it? If you do a tertiary intervention, you have to be able to maximise its outcome. So we're fortunate to build that in, and if you receive botulinum toxin, you always receive a series of funded therapy sessions that can be done by the community. Now, this is on top of already your community-based therapy. So I think it's always largely, of course, been targeted around maximising the goals that were chosen pre-use of botulinum toxin, and largely in the ambulant children, it's really focused on strength training.
Yeah, and I think that's the part that I think we really need to focus on. We've spoken previously about the upstream effects, and you never look at one treatment in isolation, and this is really truly integrated. Can we talk a little bit more about what that means for someone, or what you would say we could do for someone who's, say, GMSS level 4 and 5 in the non-ambulant population? What sort of things do you think should follow on from that after botulinum toxin?
Well, I think once again comes down to the goals of use for botulinum toxin. So for many children, GMFCS level 4, it's about maximising the use of their walker, or enabling them to participate in physical therapy programs that maximise their cardiovascular output, be it locomotor training or hydrotherapy, where they can be more functional there, have more output, therefore contribute to fitness, strength, cardiovascular health.
Yeah, sure. Yeah, and it's looking at it from that lens.
I think that's really important. I think if you reduce pain, you improve children's sleep, you improve their quality of life. So often those goals are as important as anything. So, and I think also empowering the parents, if we can improve their comfort and endurance for seating and participation at school, I mean, they're really powerful goals, and I think we need to ensure we keep on track with them, but I don't think we should underestimate how much they mean in the long-term day of the child and the family.
Yes. Yeah. Yep. It's beyond R1 and R2. I really like how you said that. So much more.
Yeah. So Jane, how has this work and the outcomes of this research contributed to the way the programs run in Kids Rehab WA?
Well, I think this is I think it's really from the senior clinicians in the department, both medical and allied health. I think we've been really reassured. We think our children have had good outcome. We really wouldn't have continued the use of this medication without thinking that. But I think that we feel that we also knew that we didn't treat everybody, but, being able to say that and show it are two very different things. So I think understanding the population is really important. We've gone on to develop algorithms of use for over age and time for the children in different GMFCS levels, really showing the rate of use of botulinum toxin for each age and each level. So, and able to show parents that, well, really, actually, you're not likely in our service to receive this more than this. So I think it's reassured us. I think the stability's been reassuring, understanding the limitations of that. And I think we will continue we really need to look at the children in a more comprehensive way of motor assessment, I think, as the limitations of GMFCS are really recognised.
Yeah.
And obviously GMFM, we've looked at a sub-cohort, but we need to look at it in more detail.
Yeah. And for clinicians and families outside of Kids Rehab WA, what would be kind of, I suppose, your take-home messages from this paper for them?
Well, I think the risks of use are always when there's funding for procedures. I think we're largely the sole providers in a whole state. We're a tertiary government-funded hospital. I think that it's important to say, well, here's a comprehensive population with stable outcomes and this is frequency of use. I think that's important. I think there are risks of concerns of over-treating children for procedures that are funded, and I think there's some concerns driving that internationally, and I think we need to recognise that. So I think producing population-based data on potential rates of use with good outcomes when there's comprehensive other services is really important. And, it comes back to the point that botulinum toxin is not used in isolation and it's not used without tracking and documenting outcomes and goals.
Yeah, that's right. And what we haven't quite touched on is then the other part of it in terms of surgical interventions and the role of botulinum toxin leading up to potential surgery or after surgery. Can we talk a little bit about that, Jane?
Yeah, sure. I mean, I think really if you're looking at children in GMFCS levels 1 and 2, the rates of surgery in our population are very low.
Yeah.
I suppose go back a step to say we're really fortunate that we have an integrated service. So we have access to botulinum toxin surgery, medication, ITB pumps, SDR. So, when you have choice, you ensure the child and the family have opportunity to understand where each of those interventions sit, and you're not forced to choose one more than the other because you don't have access. So I think we've got to acknowledge our comprehensively funded health system in Australia, which is really important. But back to the fact that recognising and reassuring parents for children in GMFCS 1 and 2 that the rates of surgery are low overall, and that obviously the rates are higher in children GMS 3, 4 and 5. But basically our use of botulinum toxin in those groups of children was largely pre-op. And then, of course, trying to get them through to a period of time and then definitive orthopaedic surgery is done, building a period of stability for the child. Now, there's still a cohort of children that obviously have ongoing issues with pain and care and comfort that we will continue to use the botulinum toxin for.
Yeah, it's great to see how that actually sits in context. There are often questions, aren't there? When you're sitting there, you're talking to the families, they're like, well, how many times will I have Botox and when will I have surgery and how often? And this just gives it a great context of when you might have it. It's not a high frequency of it. And if you do have to have surgery, you're not likely to need a lot more after, but it depends on your goals and the team.
I also think really the hardcore question is if my child had cerebral palsy or my grandchild and was GMFCS level 2 with diplegia, would I use botulinum toxin? And I would. I mean, I'd use it in a comprehensive service and I would do what we're doing. I'd track them, but I wouldn't exclude them from something that I think offers them function over time as long as we do all the other things.
That's so important.
Yeah. And so where to next with this body of work? Where do you see this research heading?
Well, I think two things. Our ideal was to build in GMFM assessments on entry into the service and at regular ages, and whilst we're a well-funded service, we haven't quite stretched that far just yet, but I think that remains our goal. And I think the other issue is we've established a large comprehensive early intervention service, and obviously we're seeing children very young and really I think the safety profile for botulinum toxin under 2 is high, but with caution in select patients, we see that it's certainly having a role, but we have to be very careful and track that. But I think we need to use that critical period of neuroplasticity and maximise functional recovery.
Yeah. And I suppose that's the because the paper that we're talking about today, that was the ages that you were looking at were 8 through to 17. So there's a bit of a gap there.
And in that study, the average age that the children started their first dose of Botox was 3.
Yeah.
So I think, we're pushing that back, but in a subset of patients. Still, we're really doing a lot of much more targeted, enriched environment interventions.
Yeah, well, that's really exciting.
That is wonderful. Well, thank you so much, Jane. We have this amazing opportunity now to go to our next segment, Tell It to Ed. Now, Ed is our producer, and as we know, he doesn't have a background in child health, but I do think he's learning and he's getting a great insight into the area. So this is an opportunity to be able to tell Ed about what this article was all about in about 60 seconds or so. I won't time you. It's okay.
No pressure.
But it's a good opportunity to be able to practice how we can say this to anyone who might not be a researcher or a clinician. Take it away, Jane.
Hi, Ed.
Hey.
I think the aim for me for this study was to really review the use of botulinum toxin in a comprehensive service over a long period of time in a large group of children that represents a complete population. And I think we can be reassured that we don't overtreat children, that with all of the comprehensive services that the child needs as well as botulinum toxin, the children do well. And we should continue to use it. We should continue to be cautious, but it certainly has a very important role in improving the functional outcome of children with cerebral palsy.
That's great. Well, thank you, Jane. Ed, do you have any questions?
Well, I have lots of questions, as usual. So I was a little excited to hear that the topic today was Botox, and then I realised, well, it's not the kind of Botox that I know about. So for full disclosure, I was explained what GMFCS levels are and how Botox works.
He has been learning.
Kids.
See, yeah, we've got it. Good.
I've been getting there.
Honorary doctorates.
Fantastic. But I guess, and I'm probably going to go off script now just so I can kind of understand whether I got this in total. Botox in kids seems to be the great facilitator, that it enables other quality of life aspects outside of just the Botox treatment itself and the benefits that has. And obviously there's been a little bit of discussion about the, what's the word for non-benefits?
Side effects.
Side effects.
There we go.
Yes. Okay.
Yeah, the risks.
Okay.
Nice. So if it outweighs the risks, then I guess from my understanding, Botox is something that should be very easily recommended to people in that situation, or is that too simplified from a layman's perspective like my own?
I think general principles are correct. I don't think botulinum toxin is a highly toxic medication. I think it's safe in the doses that we use it, but I don't think we use it lightly. Okay. I think we're still very cautious. I think every child we see, it's a new decision. Should we be doing this? What's the least dose we can use? Are we making sure we provide the post-intervention services that are required? And ultimately, the work is seeking to look for treatments that create muscle growth, that create there is a world of other ways to look for muscle recovery. They're not available yet, but that's where we've got to go. That's the long-term goal.
Yeah. Ed, I'm impressed. That was a good question.
Thank you.
Well done.
I had to think about that long and hard.
Yeah, that was a really good one. Well, thank you so much, Jane, for being on the ResearchWorks podcast. I learned so much from that. I know everyone will have so much to take away from that too. And as per usual, the run sheet notes will be on our website, researchworks.net. And of course, if you want this recorded as part of your CPD, there is a form you can fill out there as well with reflection notes, and you can have that as your record as well.
Next week, we're going to speak to Dr. Nuala Gibson and Dr. Kate Langdon. We're really excited to discuss with them their latest article, which is gaining a huge amount of attention because of its significance and importance for individuals with cerebral palsy. The article is titled Prevention and Management of Respiratory Disease in Young People with Cerebral Palsy, a Consensus Statement. And we really hope you can join us for that one. Thank you so much for your time today, Jane.
Thank you. Thanks,
Thank
guys.
you.
That was fun. Thanks.
Yeah. Talk to you guys next time. Bye.
Bye.